So we'll start with Dr. Ben Buchanan, who is a clinical psychologist from Foundation Psychology here in Melbourne, Australia. Dr. Buchanan is a clinical psychologist who works exclusively with clients with body dysmorphic disorder. He's also the co-founder of novopsych.com, a software platform that helps clinicians use psychometric science to improve patient outcomes. So I'll hand over to you now, Ben, if you want to get started.
Thank you very much. And gosh, this has been a great day. I mean, I used to be a researcher and now I'm just a mere clinician. And so I used to know what everyone was talking about with their statistics. So I'm going to try today to translate some of the research findings that I've come across over the years into how we can work with people with body dysmorphic disorder, and in particular, look at the treatment outcomes of what we can expect with body dysmorphic disorder. So, we've been talking about mostly eating disorders today. I mean, and there's obviously a massive crossover between eating disorders and body dysmorphic disorder, and really come under the body image problems. And I'm going to be talking today about some metrics that we can use to track treatment progress for BDD and characterize the research showing the typical outcomes for someone with BDD. BDD has a reputation for being difficult to treat because people with BDD often don't have great insight into believing that they've got a psychological problem. They often think it's a physical one. But there is some good news that we can get good treatment outcomes. So body dysmorphic disorder, or BDD for short, is a psychological problem where someone believes that they are ugly when in fact they look pretty normal. It's characterized by an excessive preoccupation, and importantly, the diagnostic criteria requires that people have some ritualistic or repetitive behaviors associated with that preoccupation. So in that way, it's a little bit like OCD with that repetitive and ritualistic behaviors. And so this is what a visual representation of what it might be like to have BDD, what we see and what someone with BDD might see of themselves. And now there is some conjecture over whether BDD is actually caused by visual processing differences in the brain. And the answer is, well, maybe sort of, but it's not the whole story. And we'll talk about that in a moment. People often talk to me about BDD. I talk about it in the media a lot. The media loves talking about body dysmorphic disorder for some reason. I think partly out of guilt that they feel like they've caused it, because they, how the media is, they're all like image conscious and and superficial. And so they like talking to me about BDD. And what they often say is, oh my gosh, has Instagram caused this? Has the media caused this? Have we all become a bunch of narcissists? And the answer is, probably not. Body dysmorphic disorder has been around for a long time. And in fact, it was characterized in 1891 as dysmorphophobia, which was described as the subjective feeling of ugliness or physical defect, which the patient feels is noticeable to others, although the appearance is within normal limits. The dysmorphophobic patient is really miserable in the middle of his daily routines and everywhere at any time he is caught by the doubt of deformity. And I think that this is a really excellent description. And I like the bit about in the middle of the day and daily routines, he's caught by the doubt of disformity. And this really hones into the fact that BDD is a disorder, I think, of attention, where people are obsessively preoccupied and cannot move their attention away from their appearance. And really, BDD has been hiding in plain sight for a long time, even though it is a very under-recognized disorder. Clinicians don't know what it is. Certainly the general public doesn't really know what it is. But mirror, mirror on the wall, who is the fairest of them all? If that's not like the most ridiculously obvious reference to BDD, then I don't know what is. But we all grew up with this nursery rhyme and accepted it and didn't think anything of it, even though it's probably deeply pathological. So is BDD important? And I think the answer is yes. It's not just a first world problem, as it's sometimes characterized. It's got probably double the prevalence of something like anorexia, and has a similar level of psychological impairment. And it's pretty common among people seeking cosmetic procedures or dermatological treatments. And for those clinicians there or researchers working in the body image space, perhaps in eating disorders, or just with people in general, it's interesting to think about the differential diagnoses for BDD, because BDD is not well recognized, is underdiagnosed, and the average time it takes someone to get diagnosed with BDD after onset is about 8 years. And so this is a great table showing that OCD resembles many other disorders, particularly OCD, because it's got time-consuming and repetitive behaviors. But unlike BDD, OCD rituals don't involve an attempt to correct a perceived flaw. And BDD's also got a whole bunch of comorbidities that I won't necessarily go into, but I mean, some interesting ones are like very high comorbidity with borderline. Here, I've recorded anorexia, there's some comorbidity, but the diagnostic criteria of anorexia and BDD, they've specifically made them mutually exclusive, in that in the BDD diagnostic criteria, if your main obsessive preoccupation is shape or weight, then technically, according to the DSM at least, you don't have BDD. Although, as we know, it's probably more fuzzy than that. Often people with BDD get cosmetic surgery. I'm often interested by people, deriding cosmetic surgery and saying it's just buying into this problem that we've got in society. But the research shows that the majority of people that get cosmetic surgery are actually happy with the results, and cosmetic surgery might actually confer psychological benefits on people. So I'm absolutely pro cosmetic surgery, but very against it for people who have BDD, because people with BDD have really bad outcomes from cosmetic surgery, fundamentally because it's not a psychological problem. It's not a physical problem. If you try and treat a psychological problem through surgery, it's not going to work. We know that a huge proportion of people that are getting seeking cosmetic procedures probably have BDD, which is, in my view, a contraindication to it. And the research shows that 83% of people with BDD who get cosmetic surgery experience either no improvement or worsening in BDD symptoms afterwards. So what causes BDD? Well, I don't know, the same stuff has caused everything, biopsychosocial model. There's research showing that, people who are young, who are teased, have more BDD than those who don't. BDD is highly genetic. It's very closely linked genetically to OCD. And social influences such as Instagram do probably influence a bit, but it's not the whole story. So what I'm interested in is how we translate this into actual practice. And so some research, for example, shows that BDD is largely genetic. And so the way I use this knowledge that lots of you researchers create, so thank you, in my clinical room is by saying to clients, it's not your fault. You're not vain. It's not some defect or problem in your character which causes you to have BDD. It's genetics' fault. There's heaps of research showing that there are neurobiological differences in BDD. In my research years ago, we put a whole bunch of people in an MRI scanner to look at their brain. And from that, all those years of research, that's translated into the clinic room, me being able to say to people with BDD with authority, your amygdala is misfiring in your brain. This is the thing that's causing you distress. It's not your appearance that's causing you distress. We know from the research that it's your amygdala. And so this is essentially externalizing the disorder and really trying to undermine the shame that people with BDD have. People with BDD have so much shame about their appearance, but really the shame is pervasive. And we know from the research findings that there's differences in visual perception, for example, detailed versus global perception. And so in my therapy room, I say to clients, you're not making it up. Your brain processes visual stimuli differently. I believe you that you see it that way, but I also believe the research showing that there's differences in the way you perceive it. And so I spend a lot of time in my therapy room, pointing at the amygdala in the brain, saying it's your amygdala's fault, it's not your fault. The amygdala is causing you to get into the fight or flight response and feel distress around your appearance. It's not your actual appearance. I also spend a lot of time doing, psycho-ed and talking about visual perception. If you guys can all have a look at this image and see if you can see what image it is, this is an example of detailed perception versus the Gestalt. So what probably most of you see is Lego pieces. But if you blur your vision and look at it, you might be able to see what's there, which is a very famous painting, The Girl with a Pearl Earring. People with BDD are probably looking at their face most of the time as individual pieces of Lego rather than seeing the Gestalt. I also talk to people in the room about visual perception problems. This is a pretty famous thing that went around social media a few years ago. Half of the people see this dress as black and blue, half of the people see it as white and gold. And so in the therapy room, I'm talking about this, just to give people with BDD an alternative explanation for why they see themselves as so ugly. And we talk about some of the neuroscience behind that. People with BDD often say, yeah, but being good looking really matters. Being good looking, people like people who are good looking better. And I happen to know that the research shows that even babies prefer attractive faces. And there's research showing that looks matter in all sorts of spheres, including teachers grading more attractive students higher. And people with BDD will come into the therapy room and say, I have to be good looking because it confers all of these advantages on life, and I cannot go on living if I'm not good looking. And I'm not there to argue with them about that. Being good looking is an absolute advantage, and Kim Kardashian will tell you that. But it's about meeting them where they're at and also providing an alternative. Yes, people like good looking people more, but people also like people who smile or use their name or listen and are humble more. And there are a whole bunch of things that we can do to gently undermine the obsessive occupation with having to be good looking. So what are the treatment outcomes for people with BDD? Well, the research shows that there's a meta-analysis that shows that it's relatively effective, and there's a Cohen's D of 1.22, which is pretty good as far as treatment response goes. But with CBT as the treatment that I use, only 40 to 50% of people are responders. And this is in contrast to OCD, where 60 to 80% of people are responding to treatment. One thing I do in my therapy is that I assess everyone with the appearance anxiety inventory, which is just a 10-item questionnaire at the start, middle, and end of treatment. And this is a typical result of something, or this is not a typical result, this is a very good result actually of a client of mine, which shows their percentile rank compared to the general population on the AAI. So you can see they're scoring essentially 99th percentile, and then that reduces. But that person, this is the same person on the depression, anxiety, stress scale, while the depression, anxiety, stress was super high early and then reduced, they've still got significant problems even at the conclusion of treatment, even though BDD has been successfully treated. And in my private practice, I looked at all the 36 clients that came through my door, and saw that at the start of treatment, they had an average score on the AAI of 28, and at the end of treatment, they had an average score of 18. 69% of people improved, 0% deteriorated, which is, I think, a fluke, and 31% had no material change. And my Cohen's D was 1.24, which is roughly equivalent to the published research. So this is my attempt to briefly say how I'm translating all of the research that you wonderful researchers are doing into my clinical practice to help clients. Thanks very much.
Fantastic. Thank you so much for that, Ben. That's been really, really insightful to see. So in terms of your practice, you said that a lot of people struggle with getting insight into their symptoms. Is there anything that you've noticed that tends to help shift insight or that might predict a change in insight?
Yeah, great question. I think I've got an easy job because by the time that people see me, they've already got a level of insight because they've made an appointment with me and they know I treat BDD. The problem is that most people have never heard of body dysmorphic disorder. And the thing that I think gives people that aha moment and they go, oh, maybe I'm not terribly ugly, maybe it is a problem, is usually when they see something about BDD on the internet, in the media, and they think, oh my gosh, this is a clinical entity that is real and that people struggle with. And so that is, I think, that's why I'm so keen to get the word out about BDD so that people can have that aha moment.
Yeah, great. And I just had one quick question. At your slides on the end there, we saw people improve greatly with their appearance anxiety. Then there was a little kick at the end, and on the desk was sort of went a little bit all over the place towards those last few weeks. Do you just want to say what could have been going on there to that person?
Well, I think that people with BDD who come in usually have a variety of other problems. I mean, this is the clinical world where they come in for BDD, you treat them for BDD. I tend to really target BDD, whereas, their life might be falling apart in some other sphere. And so I suppose this is just a representation of how messy doing clinical work is, and you rarely get someone with BDD and BDD only.
Right, so it's a very complex problem that probably requires a longer term approach.